Claire, we're now live.
Dr. Kim Lim will be presenting the third of her series of webinars tonight on shoulder rehabilitation. For those of you who are present for the last two, you'll know how beneficial they have been, and we're looking forward to tonight's webinar. So many of you know Kim. She needs very little introduction. She's the current past president of the Australian Veterinary Acupuncture Group. She has qualifications in acupuncture, chiropractic, and most recently canine rehabilitation, and she has a vast amount of experience in all three. So if you have any questions, feel free to type them into the question box on your screen. We will field questions at the end unless I see something that's really pertinent to what we're talking about. And otherwise, I will hand over to Kim to start tonight's proceedings. Thanks, Kim.
Thank you, Claire. While I remember, to the bottom right of your screen, you can see a little folder icon. So you can download the PowerPoint as a PDF if you want to follow that while I go through it. And I will have this webinar on our AVAG website as well. We'll save it later down the track when it's all processed. Anyway, let's start. So I'm going to be talking about shoulder rehabilitation. Now, it is a personal story with this PowerPoint. So there are things, obviously, that other people do with shoulder rehabilitation that I don't have any experience with. So I won't really be touching in any depth on those. So moving right along, that's me. There's my, let me get my little pointer. And a dot. So that's my website. No, that's my email and my contact number if you have any other questions after this webinar. Okay, so conventionally, and we're kind of going to be talking about shoulder rehabilitation and shoulder lamenesses from a medial shoulder instability point of view, although I diagnose mine from a slightly different angle, from a chiropractic type angle. So we will still compare it to the conventional medial shoulder instability problem. So conventionally, how do we treat it? There's medication, painkillers, lots of different types of painkillers. It was very popular at one stage to inject intra-articularly into the shoulder joint with cortisone. The surgeons like to cut everything, so, you know, sometimes they cut the bits that are damaged so that there's no more pain. And then there's also the use of hobbles as part of a rehabilitation procedure. I don't have any experience with the hobbles, so this might be something that would be good to generate discussion on its use for the people that have tried it. But the way I look at it, it's sort of a catch-22 situation, because medial shoulder instability means there's instability, which leads to pain. And then there's muscle wastage because of disuse, and the muscle wastage then leads to more instability, so it kind of all feeds on itself. So how do I approach this? Let's move to the next slide. So from a timeline point of view, I look at it as a problem that's the longest to rehabilitate of all the limb lamenesses. And why is that important? Because you need to give your client some sort of benchmark or estimate on how long to expect this problem to resolve. Why does it take the longest? I think because 60% of the dog's weight is over the front legs, so they take more weight than the back legs. So if you're rehabilitating a cruciate, it might not take quite as long. And you don't actually have a bony articulation in that area. As we all know, the shoulder girdle muscles are the ones holding it together. There's no collarbone. So these shoulder girdle muscles are constantly activated to hold the weight. They don't get a rest. Okay? But in all the ones that I've done, if the owners are diligent and committed, then it is definitely an option worth considering. And as I said, it can take a while, so 6 to 12 weeks if there are no setbacks. And often there are, because, you know, the dog will see a rabbit or something else, and then it'll be sore afterwards. Okay. Obviously, we've got a differential diagnosis. So Again, I look at it slightly differently. I mean, obviously, you know, if you look at the bottom, you've got your bony changes, osteochondrosis, sarcomas, and osteoarthritis. Those sort of things means that there's a reason why there's a lameness there. But from a biomechanical point of view, if we go to this slide, this section, if something is tight, there'll be a compensatory relaxation or loosening elsewhere. So when you look at the top bit, secondary to restrictions elsewhere, the glenohumeral joint can become hypermobile. So if it was really tight between your shoulder blades in your thoracic vertebrae, then the body still needs to move. And often I find that the scapular, that glenohumeral joint is the one that gives way and becomes more hypermobile. And the same goes for any elbow dysplasia or carpal osteoarthritis. If there's restriction in the range of motion of those joints, then it might lead to a compensatory hypermobility in the shoulder area. And even the hind limb deficits, you know, if you've got, as we've said before, a cruciate problem or a hip dysplasia, then you're going to tip that weight forward more into the front end and then overload that front end. Okay, so I think we're going to the next slide, which is a little video. So I'm going to present these two videos as a typical type of lameness that I see when it gets presented to my clinic. So let's play this video now. Now, we were having a little bit of trouble with the videos. They were a bit slow to load, so just bear with us. I can't see it yet. Just wait for it to come on. So while we're waiting for the video, I'm just going to repeat that in that bottom right corner of your screen, there is a folder icon, and you can download the PDF of this webinar there. No, can't see the video yet.
It was playing on mine, Kim.
Oh, was it? I don't know why I can't see it. It's just me.
Playing again now, the small white floppy.
Yeah, I still can't see it. I'm not sure why. Nope. Okay, I think it's going to come soon. For me. Okay, well, shall I pretend you've seen the video? Has it played a few times, Claire?
Yeah, it has played a few times. If anyone wants to comment in the text box on the bottom left and let us know if anyone else can see it or just me, that'd be great. Thanks.
Because I still can't see mine. Anyway, the first one for those of you that can see it, is a right shoulder lameness, and then the second one is the left shoulder lameness, which is the bigger other fluffy dog. And don't forget, if you've watched the 10 tips videos, the webinars, we can slow these down on a slow motion app. Oh, there you go. I can see it now. Okay. Is it going, Claire?
I think it's just at the end of one at the moment.
All right. So do I get it to go? Or I see it. It's just my problem. Anyway.
Yeah.
So
quite a few times. So do you want me to go back to the slides? Or?
No, that's okay. If other people have seen it, I can pretend that I've seen it too. I know. See, Anna says she's just got an empty box. So for those of you that are having trouble seeing it, I have put YouTube links on all these PowerPoints, and go right ahead to click it, or you can watch it later on, whatever. And then when you've downloaded the PDF, these YouTube links will operate as well. Yeah, I don't know why other people can't see it. Well, some people can and others can't. Oh, I hope this is not going to be a problem for all of them. Okay, so they're happy with their YouTube link. So let's go back to the PowerPoint then. There we go. So then, once we've had a look at this typical sort of lameness, it's not a toe touching type lameness that says it's lower down in the foot or something like that. Okay, this is how I examine the dog for this particular type of lameness, which I find in nearly all the shoulder lamenesses. I stand behind the dog and wrap my hands around the front of the chest of the dog, and see my hands are around the points of the shoulder, and then my fingers are in that little divot in that thoracic inlet, either side of the shoulders. And what I find is that there's often big space on the one that's lame, and there'll be a lot of muscle wastage in that spot. And that's where my fingers are wrapping around, is where the omotransverse areas is. And then if you go lower down here, where your pectoral muscles are, so the lame shoulder that's affected will often have hypertonic pectoral muscles, with trigger points and spasms in there. And then when I get them in lateral recumbency and have a feel of the texture of the biceps brachii and stretch it out, I find that it will often be tight, with a reduced ability to flex that shoulder and extend that elbow. And don't forget, so the function of that biceps brachii is to extend the shoulder and flex the elbow. So when you're trying to stretch it out, if it's short, if there's scarring or trigger points there, then you'll have trouble doing this action. And most of them tend to be in that mild stage. So if you pull it back and it goes all the way, then you're kind of suspecting that that biceps might actually be torn, and so there's nothing holding it together. So if we do a little recap on the different gradings with the muscle tears, we've got grade 1 being mild damage to individual muscles, maybe muscle fibers, maybe about 5%, with minimal loss of strength and motion, and they can take 2 to 3 weeks to rehabilitate. For other muscles, but I find with the shoulder, because they have to use that leg so much, it can take a lot longer. Grade 2 is more extensive damage, not complete rupture, with significant loss of strength and motion, and that can take 2 to 3 months. Grade 3, as I've described before, is a complete rupture with a palpable defect, so a really big hole, and may require surgery to reattach. But as I said, I have had one that you stretch that leg all the way, there was no pain, there was no resistance, big deficit there, but we managed to rehabilitate it with time. And the surgeons do cut that biceps brachii tendon if they think that there's so much pain that that's one of their options. Okay, so let's do a bit of a recap on the anatomy. Here's your biceps brachii. The origin is your supraglenoid tubercle, and it inserts on that medial tuberosity around the elbow. So the action is to flex that elbow and extend the shoulder. And this last bit is quite important. The innervation is around the C6, 7, and 8 area, and we'll go through why in a minute. Now, conventionally, this is how they test and diagnose medial shoulder instability. So they're testing the integrity of the medial glenohumeral ligament, which is a little bit different to that biceps brachii strain that I see. So they extend the shoulder and abduct it here. So you're stabilizing your scapula and abducting. And normally it's around less than 40 degrees. Obviously you compare both sides. There has been a bit of debate about that scapular position. Do you extend the whole leg or do you keep it in a neutral 90 degrees position? Doesn't really matter as long as you're consistent, that you do the same thing each time. And then you can compare it. This is the second test. It's the medial glenohumeral joint glide. So now we're testing the integrity of the glenohumeral joint capsule on that medial side. So you're stabilizing the scapula by the body wall and your index finger, this bit here, on the supraglenoid tubercle cranially. So making sure that doesn't move. And then you're putting a downward pressure on your humerus to see how much glide there is. And it should be the same on both sides, and it shouldn't be painful, or there shouldn't be a clunk either. And then the last test is to test the integrity of the subscapularis. So if you look at the subscapularis, this is your medial view. Origin is your subscapular fossa, and it inserts on that lesser tubercle of the humerus. And its action is to adduct, so bring it closer to the body, and extend the glenohumeral joint, so bring the shoulder forward. So this is what the test looks like. You're flexing that glenohumeral joint, and then you're externally rotating it that way to check whether it's painful, whether there's a tear. If there's no pain and it goes all the way, then you know that it's a full tear. But if it's painful and it goes part of the way, then it's a partial tear. But hopefully it doesn't go at all and it's nice and tight, then you know that that's not damaged. Okay. So if we look at a simplified view of the forelimb neurology, you can see that a lot of the innervation from the caudal cervical vertebrae and the cranial thoracic vertebrae, this is the important area where your nerves feed into the front leg. And why is that important? Because, okay, so that we'll talk about that later, on how that the restrictions in that area will affect the neurology of the foreleg. But if we then move to, so that was diagnosis, and now we're moving to a treatment point of view. We are all acupuncturists, and so we have skills with acupuncture. And these are the different possibilities that we can use to improve it. So we can use local points. I like lung 1 because it's in that pectoral muscle. And then the cranial eye of your shoulder, large intestine 15. So these are just some simple pictures, and you either know or you can read where the landmarks are to insert the needle. And then from a lateral view, so the large intestine 15 is your cranial border of your deltoid, and the caudal eye of the shoulder is triple heater 14. These are all local points that you can use, which I'm sure you've all been taught in the past. And then there's the balance technique that's been made popular and famous by Dr. Richard Tan, and I've talked about that with the 10 tips as well, where if it was a shoulder lameness on the left, and so it's on the outside here, so you've got a young meridian there, you can use the contralateral young meridian on the back leg. So that would be the bladder or stomach meridian, or you can use the contralateral front leg and the ipsilateral back leg yin meridian. So it's sort of yang, yin, in a balancing technique, and then you would do it all at the level of where that shoulder was. So shoulder here, hip here, and hip here. And this is called the mirroring technique. A variant of that is what Robert Doan does in people. So you've still got that same reactive shoulder, and you could pick the contralateral hind leg, the bladder meridian. It's probably easier, and you would do multiple needles around the bladder meridian in that hip region. Distal points, so if you've got intestine 15 here, you can draw that irritation and excess energy down through the large intestine meridian. So the usual suspects, 11, 10 and 4. Or you can use a balancing technique and draw it down on the lung meridian. If it's on, if the reactivity, as I said, lung 1 could be reactive, use 5, 7 and 9. Okay, electroacupuncture, so I used to use them quite a lot for trigger points, but they're also useful in cases where you want to strengthen that wasted muscle. Okay, so I talked about the trigger points and spasms in the pectorals as it's using all its effort to try and pull that, adduct that limb. But trigger points are also commonly found in shoulder lamenesses in your deltoids, your triceps, teres major under there, and then higher up in your rhomboids, under there, trapezius in your lat dorsis, and then your brachiocephalic, which kind of in the cranial area, and it's more a neck problem that I find that brachiocephalicus can be irritated, but it follows some of that biceps pathway too. And obviously this is a dissection and of a greyhound, so you can see that muscle structure very easily. So this is just a useful slide for you to go over later if you wish, all the different muscles and where they are. Don't really need to do that here. There's obviously other methods of dealing with trigger points. Mark Hocking has his Eastin type method. Some people inject different products in there. You can use prolotherapy for those local points. So something, there's different options. I like to also add herbs to it sometimes. So these are my favourite ones for any sort of tightness and pain in the muscles in that front half of the body. So Chaigo Jiejitang, good for wind, so muscle layer, and clears Yangming, Taiyang pain and paralysis, especially in the neck region, so good for disc problems there too. And your Shuifu Juyutang, which is a very popular formula for blood stagnation and circulation, especially of the upper jowl. Now we get to the rehab part of it. So we've got a biomechanical assessment, which is the other hat that I wear sometimes when I'm teaching the biomechanical medicine course, which is a chiropractic osteopathic course. So I like to assess in that standing position. You remember me standing over the dog, wrapping my hands around that shoulder into the chest. And then I assess the thoracics, the cervicals, the ribs, all those sort of things, because as I said, if something's tight in one area, it's going to be hypermobile to compensate somewhere else. So I often find that T1 and T2 are quite restricted. Here we go. So if I go back, no, not really. So T1 and T2, if it's restricted there, remember that our neurology is going to affect the nerves coming down to the front leg. And if you have skills in chiropractic, then I like to adjust the T1 and T2 and the ribs as well. One of the common ones I find is the restriction right in the front there in that first rib. So this is one option if you have those sort of skills. If you don't, this is another option, and we talked about this with our 10 tips webinar. We can do a harmonic rocking type technique, and I'll go through that again for you in a minute in the video in the next slide. So my emphasis is on treatment at this stage, because if we don't get those tight structures loose, then we're not going to be able to balance and resolve that hypermobility. So rehab's all very well, but if the neurology is not right, the balance isn't right, then we're always going to have this hypermobility and tightness somewhere else. Okay, so let's go to the next slide, which is a chest release. So this is another way to release it, and I'm not sure if I dealt with that in the top 10 tips or the next 10 tips, but this is basically putting your hand on the chest and then a hand up the top to balance, and I'm very gently nudging the chest backwards and then letting it rock forwards. So you want to do it very gently, that the dog doesn't take a step back, and it's just going to sway back a little bit and then rock forward slowly. And remember what I said in the top 10 tips, slow and gentle relaxes, hard and fast stimulates. So we want slow and gentle. And the rocking forwards and backwards will open up this cervicothoracic junction and open up your thoracic inlet. Okay, so that's a sternal pump or a chest rock. Now we've got the harmonic rocking as well, which we can see in our video, and or you can press the YouTube link, and I probably won't be able to see it anyway. So we're going to just do the rocking part of this video. Yep, and I can't see it. That's okay. Claire, can you tell us when it's finished?
Not just at the moment, sorry, because my computer's logged me off. Going well.
Kim, it's still
Going well.
Kim, it's still currently playing the first video too.
Oh yeah, here we go. So just the first half of it. So did it play?
Yes, so you played the
okay.
harmony.
Yep. So now we stop it.
Yeah.
And then we go back to the PowerPoint. Yeah. So if you had trouble with that, don't forget you can click on the YouTube link. And they're all very short videos, but there's no other way to do a webinar that's really like a workshop unless you have lots of videos. Okay, so remember I talked about it being tight in that T1, T2 area, and your first rib articulates with that area, and this is how you diagnose and the problem and hopefully treat it. So you pull the scapula back, and your fingers then should be able to touch on that first rib. And when you spring it back a little bit, if there's a restriction, it'll feel really tight compared to the other side. The other side will have a bit of a spongy feel and a bit of give, and this one will be quite tight. And that's one of the things you will need to release. And you can just rock it, harmonic rocking, like we've been talking before, or you can do it like a trigger point technique where you just put a bit of pressure on it, and don't forget the dog's breathing all the time rhythmically. So that breathing will put pressure on that rib, and eventually that will release. Okay? So then or another way is that yoga breathing. Remember we talked about covering the nostril to try and get the dog to do a big breath in our 10-tip seminar. I have put the opening the diaphragm in, but that's probably more useful in that thoracolumbar junction rather than up front. Okay, so now we've done our treating, we've released all those tight areas, we've got things moving quite nicely, and you should find it almost an instantaneous change in the tone of that shoulder girdle area. Where you had that big hole, you'll find the muscles will be activated, and they'll start drawing that shoulder in a little bit. They'll still have a lot of wastage, but the tone should improve, and that and that pectoral muscle there will improve a little bit too. So we move from treatment to rehabilitation. So remember, we talked about this in the top 10 tips. The first phase of the treatment is to undo the problem. Then we fix it, give the body the right pattern, and then we strengthen it. So which phase are we up to now? Let's have a look. So this is, in the first phase, we can use heat or we can use cold. And as I've said before, I prefer to let the dog choose, because if it's going to wriggle away from one or the other, then it's not much use. Okay, then we go for stretches where there's tightness. And we've seen this slide before, passively stretching it in the correct direction. So you do need to know your origin and insertion of your muscles in that area. And you can use towel aids and stuff like that too. So here are some, just briefly, some stretches. You've got your neck stretches, or you can call them carrot stretches or treat stretches. Remember, I talked about stretching that scapula back and working on that first rib to open up the thoracic inlet. And we talked about counter strain in the top 10 tips. Counter strain is to take something to ease, asking it, and then once it's nice and relaxed, so we're taking our biceps brachii and our descending pectoral to ease in this one. And then we're stretching it, so then we hold it for 90 seconds. And at the end of the 90 seconds, your myofibral cross fibers should have relaxed and disengaged. And then you can take it to a nice stretch without it causing so much pain. And I've sort of combined both the biceps as well as the pectoral here. So I've got this leg angled at 45 degrees up. So I show my clients all these and get them to take videos of it so they can practice it at home on that leg. So you've got your brachiocephalic here, so you've got to stretch that neck up. Here's another angle of the biceps brachii stretch. And then your pectorals, so transverse goes across, ascending comes up. And then don't forget these caudal muscles, your subscapularis, deep pectorals, lat dorsis, those sort of ones. So then we talked about it being tight in that thoracic region. So then you might have residual tightness on trigger points in your rhomboids. They come up this way from the spinous processes. So you can wing your scapula out, and then you can also do the scissor stretch with the front legs. Your triceps, don't forget it's not enough just to stretch your foreleg forwards. You've also got to bend that elbow and try and tuck it behind the head, just like you would do a tricep stretch in a person. This is not about muscles, but I put it in as well because I have had occasions where shoulder lamenesses have been caused by restrictions caused by scarring and other structures in the way, like lipomas and things like that. So if that is the case, you do need to do some soft tissue work on that. This is another way to release the scapula if there's a lot of tightness in there. We might have gone through that before. So the passive range of motion, extending, flexing in a rhythmic manner to the full range of motion. And that tweener technique we dealt with last time, DOFA, which is what I call the shake it like jelly one. So this 44. So we're going to go on to the second half of that video at this stage. Oh, look at that. I can actually see it. So this is your shoulder roll. I tend to do 5 in one direction and then 5 in the other. So you're rolling the scapula around, not just the front, the leg. And then we can see this next one, which is the passive range of motion, or I call them leg pumps. And because they're rhythmic, the dog just gets distracted. And you can see the shaking relaxes that dog, and I can get a much better stretch than if I was just doing it without the shaking. Okay, so now we can go back to the slides. Okay, so now we've really taken everything apart and released it all. We can get onto the strengthening phase, which is probably what you're all here to hear. So where there's weakness and there's good balance, now's the time to get into the strengthening, and that's third phase. Now, if you don't take anything else home, this is probably your most important slide, because this is a muscle rehabilitation sequence. It tells you in which order we need to do certain exercises to rehabilitate a certain muscle or any muscle. So I want us to do a little exercise at home at the moment, and I'm going to explain what these terms mean. Okay, so we'll go through the first one, and we're going to do it on our own biceps brachii because it's nice and easy. Open means that the free end of that muscle, so in this case it's your hand, is not stuck to anything. It's just flopping in the breeze. Eccentric means the muscle is lengthening. Now, how can it lengthen if it's actually contracting? It means that it's a controlled lengthening of the muscle. When you, so let's do this. I want you to touch your shoulder with your hand, and then I want you to extend that elbow. And you can see that when you extend the elbow, it's not just gravity dropping that arm all the way down, but you've controlled that descent of that muscle. So you would do that as your first phase. And then let's do the next one. So closed means that your free end is now attached to something immovable. So I'm sitting at my desk and I can hold on to the table. Table's not going anywhere. So now my free end is attached. That's closed. Isometric, most of you probably know, means it doesn't change length, so it doesn't lengthen or shorten. So now I want you to grab a hold of that table and tense your biceps without actually moving anything. So that tensing means it's doing an isometric contraction. It's still working, but it's not lengthening or shortening. So that's working it that little bit harder, and you can feel that biceps is working it harder. So then the next phase is what we call open concentric. So now your hand is free again. And concentric means it's just contracting. So that's us bending our elbow and lifting our shoulder. So we're contracting, concentrically contracting the biceps. The next one is closed concentric contraction. So now we're gripping our table again, and we're contracting our biceps, so we're bringing our body closer to the table. And we're working harder to do that, because now instead of, so we've got the weight of that body that we're trying to pull across. And then the last one, which is just as important as the others, is the closed eccentric. So now now that you're close to the table, your hand is still stuck on the table, so it's closed. But now I need you to pull back, so extend your elbow, and it's lengthening that biceps. Got that? Good. Well, we'll go through it again, but this time with a dog, and then you can practice the same moves on your own biceps if you like. So this is the acute phase, where we don't want the muscle to move too much, but we need it to do a little bit of work. So the open eccentric biceps brachii. Now I've got two. One of them is sitting in the non-weight bearing position. So in this case, the owner has lifted the leg up, and then she's going to let it drop, okay, in a sitting position. So then we look at the next slide, and this is in standing. So she's lifted the leg up, and then she's going to let it drop. And it won't just drop like a sack of potatoes. It's going to be a controlled descent. So if we can, is this when we play the next video? Yes, so we played the video. So can someone tell me when those two sequences are played?
Not playing on mine at the moment.
Okay. Can someone just type in it if they see it play? Oh yeah, well that was it, sort of. There we go. So we lifted the leg and we let it drop. See how it just dropped? It's a controlled drop. And then we see the next bit. So she lifts the leg up. This is a well-trained dog, of course, not your usual client. And it's a controlled descent. Okay, so then we go back to the PowerPoint. Yep. So that's nice and easy. That's in an acute phase. It's not going to hurt the dog to do that exercise. So in the next phase, when it's not so sore and it's not so reactive, you think, oh, I can get a little bit more strength happening. We can do the closed isometric contraction. So this one, remember, you've got your hand on the table and you're not moving your position, but you're contracting your biceps, making it do that pumpy type thing that people do. Okay, so in this case, what we can do is we can pat the shoulders of this dog side to side, so it's shifting its weight left to right, but it's not taking any steps sideways. So, and we'll show you the video in a minute. And then once it's quite good at this, we can do the next step and make it a little bit harder with a balance disc or an air mattress or a pillow or anything. You don't have to spend a lot of money on this sort of stuff. There we go. So now we can play that video, and I think this is a combined video, so we'll stop it halfway.
Okay, yep, doing the rock from side to side.
Okay, here we go. So that was rocking side to side on the ground, and this is rocking side to side on the balance fish. So it's, even if you can't see it, it's easy to imagine. That's it. So once we've finished with this one and it goes black, we'll go back to the, yep, so now we'll go back to the PowerPoint. Pause it there. Back, so there you go. And as I said, you can increase the level of difficulty as it gets better. So with a resistance band, which is pretty much just one of those elastic sports band, you can wrap it around the leg and pull it outwards a little bit so that the dog's resisting it and pulling that leg inwards. Because remember, it's the weakness adducting, pulling the leg back in. That is a deficit. Or you can do this patting shoulders side to side thing facing downhill, so it's putting more weight on that front end. Getting a little bit harder, we can do diagonal leg lifts. So if this was the bad leg, you can lift the other front leg and the diagonal back leg. And then you can also sway that dog side to side to get it to activate those adductors. And so if it's pulling it this way, then you're contracting, and if it's going the other way, then it's lengthening. So it's obviously you're not doing one specific muscle sequence at a time. There's overlaps there, but the main one is the isometric. Parastanding. So if it was a right shoulder lameness, you can lift both left front and back legs, and then you can do your swaying again side to side or forwards and backwards. Because don't forget, you need to strengthen some of the biceps brachii, so extends that shoulder forward. Okay, so then the next phase is our open concentric. And remember, open concentric means there's nothing in your hand and you're just flexing your elbow and extending bringing your arm up to contract your biceps. So you can do this. This is a nice simple thing that I like teaching people to do, high fives above the head. Why do I say above the head? Because most dogs do a high five by just flexing that elbow. But don't forget, it's a shoulder problem we need to deal with. So they've got to go above to reach their head. And I'll show you the video in a minute. So then an easier thing, if they can't actually reach their head, and some breeds can't, is to do it standing. So standing and reaching forwards, so you're extending your shoulder forward or your glenohumeral joint and contracting your biceps is easier than lifting it all the way up. So let's have a look at this, the second half of that video. So this is a little nifty trick on how to get your dog to do high fives if it's not into training, and most dogs aren't. You stick a bit of masking tape on the eye, and you can see that I haven't quite got it over the whole eye, so the dog's trying to blink it off. So we're going to reposition that, squish it on a bit more, and the dog goes, oh, get it off. So this particular dog was the one with the full biceps tear. And the owner was very diligent. She stuck the masking tape on that eye every single time because the dog refused to do the exercise without the masking tape. And this is that very well-trained body again. And you can see that extending that leg forward will also extend that shoulder. Okay, back to the PowerPoint. We're nearly there. And then in that last phase where we want to get more strength into the into that shoulder girdle muscles, we can put more resistance there. So this one isn't quite a fully closed technique, because remember, close was holding the table and then bringing your whole body closer to the table. The table doesn't move. But I like this technique. It still does the same thing. I use a resistance band. You can get them at those sporty type shops. And then I've got it in this figure of 8 pattern. So I've looped it around under the axilla, and then I go around to the other side of the body, and I loop it around again so that it's crossed over at the top here in a figure of 8 pattern, and then I just tie a bow to it. And then this is where it's really important to place it. Make sure it's on that inside of that shoulder, right in front there. And then when they go for a walk, they've got resistance when they're extending that shoulder forward. And then you can start short and gradually increase it to build up strength. This is another one, so don't forget the 2 actions is to extend that shoulder and also adduct, so those adductors are quite weak. So we can do a sidestepping motion. I've got a little video, but you can see this is what they call a luggage strap hold. So I've got a long lead and I've stuck it under the dog's belly, abdomen. And then you pretty much just nudge the dog forwards so it's walking sideways. It's quite awkward and difficult, so I don't really push it, and I go, even if you do a few steps, that'll be good enough. And which direction do you go? So you want, the exercise is to get the dog to pull the leg inwards. So if it's a right shoulder lameness, you want to go from right to left. So it's always stepping in on the bad leg. Okay. So let's have a look at the video. Here we go. Now, when we were testing this video refused to play for me, so you guys tell me when it's done. So you can see, so if it's a right shoulder lameness, we're stepping in all the time, stepping in, and going. Here we go. Oh, I can see it. And you push the dog across that way. Some dogs hate it and you give up after a while, but this gives you another tool. Okay, just tell me when you finish playing that. Oh, it's going. There you go.
I'm finished. I don't know if it's stopped.
Well, it's kind of self-explanatory. Pretty much just does the same thing for all the steps. Okay, there you go. And then to make it more difficult, you can take it over obstacles. So I like playgrounds with tan bark because that's kind of a bit wobbly and not even. So that's the uneven surfaces. You can make them go downhill. So then they're loading their front end some more. The kinesio tape and the weights will be in the next few slides, so we can talk about that. So this is kinesio taping. This is not something that I've got a lot of experience with. I have used it more with the cruciate rehab, but you can see I've got a tape around where the origin down to the insertion of the biceps and across where the pectoral muscles are. So it might be something for you guys to try. I don't have all the answers, and see how it goes. And what kinesio taping does, it pulls on the skin, it pulls on the hair, it pulls on the skin, so it keeps it activated all the time. So the dog's more aware that that this muscle needs to be used. Doesn't get lazy with it. And then the weight, this is a YouTube. We haven't included it in this webinar because it's sort of like, well, wear a watch and go for a walk. When we were at the CRI rehabilitation course, they talked about the lack of evidence of wearing weights as opposed to people when they wear weights. It seems to be more benefits. So again, I haven't had any that have come to harm. And I've had, especially for my cruciate rehab, I used to use it quite a lot. I've probably forgotten to advise my owners to do it recently, but it used to produce quite good results. So an easy one is to get an old kid's watch that doesn't work anymore. I'm sure if you've got kids, there's plenty of those lying around, or just go to the op shop or something like that. And kids' watches are very light, so obviously you've got to pick the size of dog. So this is a Dalmatian, and it can cope with this weight of watch. And so they're nice and light, and they've also got a small wristband, so you can strap it on. And then take it for a walk. So why does this work? Because then you've got an extra weight to lift, and that's lifting using your biceps brachii. I have said here it's best with the head to the ground to trigger the flexor reflex, so you can have following a food trail. Okay, so coming to more strengthening, here we've got closed concentric. So again, water is not an immovable object, but it does have extra resistance. And paddling with the front legs does strengthen both flexors and extensors and improves the range of motion. For the non-swimming dogs, you might want to put them in a life jacket so that they're not spending their whole time struggling to keep afloat. Or you can do what I like, which is to go wading. So again, you've got a sort of semi-closed because of the water resistance. And I think I talked about this with the top 10 tips, where the beach, a still water, like, you know, at the bay beach or the pond or a dam, is a little bit different to an underwater treadmill. Here's the YouTube link, but we can have a look, and this is the height I like it at shoulder depth, because that's the depth of the injury. Oh, hang on, no, now we do the video. That's it. So if we can have a look at the last video, and you can see, so this dog, when you can see it, because I'm imagining it, there we go. So the water's at shoulder height, and you can see the dog's pushing against the water to take its leg forward, but the treadmill's taking the leg back. So it's not actually strengthening its flexors, just the extensors in the shoulder. Because as I said, the treadmill's doing the work with the flexors. Okay, so let's go back. And then the last exercise is your closed eccentric contraction. So remember, closed means your hand's on the table, it doesn't move, and then your body's close to the table, and then you're extending your elbow and taking your body back. So the muscle, the biceps brachii, is lengthening slowly. And an easy exercise for that is digging. So you can do digging, which I recommend because it's easier to teach a dog to dig than to do a commando crawl. But why do we need to do this? You know, once you've got your full strength, Why do we need to do that last bit of close eccentric contraction? And I might have touched on it in the top 10 tips, I can't remember, but it's called strength at stretch. So often injuries happen when we're lengthening our muscles and we haven't got that flexibility to do that at when we've got full weight bearing or got a lot of load on it. So this is actually strengthening it in that last phase. And then I've got clients that look at me in horror and said, I've taught the dog not to dig. And it's like, oh, sorry, just put a treat or something under there and let it dig for it. Now, this is a bit of a tricky one. This is another way to rehabilitate the dog. So if the dog's bad leg is lower, means it has to use more effort to pull it back up to take the next step. So it's doing more work there. But the biceps brachii is on that medial side of the leg. So ideally, the medial foot part of the foot has to be lower than the lateral part. And there's no other easy to find situation except at the entrance to a driveway. And obviously that's not very long either. I'm sort of lucky I've got a double driveway across the road from where I live. So for little dogs, they could go up and down it, but they have to keep to this middle line. But if you can rig something up like this, this would be a nice way to rehabilitate the leg, because then it'll have to pull that inside muscle up more, work it more than any of the other muscles in that front leg. And then we've talked about restraints before. Obviously, if they're pulling, they're overloading the shoulder in the early stages and aggravating the injury. I don't have any one magic harness that will that everybody likes that will stop that. I think the canine rehabilitation CRI people really they preferred the balance harness, which is which goes under the body as a harness. But it's got an attachment at the front and at the back. The only thing I don't like about it is that it puts pressure around the thoracic inlet and it might tighten up around that first rib again. So these are the other brands that you can have a bit of a think about. And then obviously we've talked about this. Jumping down is bad for the front end, so don't let them do it. Either have a big cushion or they learn to go down a ramp. And that goes for beds and couches and anything like that. Ball games are out, so a lot of that twisty-turny type thing to chase balls overloads the shoulders. And we also talked about how chasing is out and retrieving is in. So at the moment, what they like you to do is to hold on to the dog, throw the ball, and when the ball stops, the dog can go and get it. Again, a lot of clients don't like that, but it's going to save on the injuries. And then the end result is, remember those journals we got with dogs doing amazing things on Previcox and any of the other non-steroidals? Well, you might be able to get that without the non-steroidals. So then you get a nice happy picture. All better now. So that's really the end of my PowerPoint presentation. That's what I said. It's not even on Metacam. And if you're very keen, there's another webinar which I haven't written at all. So who knows what that'll look like in 2 weeks on the medial patella luxation. Same time, Tuesday, Claire. That's it, everyone.
Excellent. Thank you so much, Kim. If anyone has any questions, feel free to type anything in the box there, although I think Kim's explained most of it fairly well. I know that I have found shoulders to be very difficult to deal with, even with the background training that I've got, so it's great to hear someone else's tips. There's certainly some pointers that I'm going to take home and have a go at with some clients.
Go at, yeah.
Yep. And as Kim said earlier, this will be available on the AVAG website page at some point in the next month. So if you want to go back and review it again and have another look at those videos so you can get the hang of a few more things, you can certainly do that.
Yes, and I will be putting a newsletter blog out in the next one about how to access all that sort of stuff, because most people have forgotten that you can access all your journals, all the past journals, and all the previous webinars on our website too, if you're a member.
Excellent. That sounds great. So if there's no other questions,
we can go to bed.
Call that it for tonight. Thank you all for coming. And a huge thanks to Kim. She's doing a great job with this whole series of rehab webinars. I'm sure everyone's getting a lot out of them. So thank you as always, Kim. It's an absolute pleasure to have you.
Pleasure. Thanks, everyone. Good night.
Good night.